you very much.
Thank you very much for the very nice and long introduction. And let me thank the organizer for inviting me and being with you today discussing about all these interesting features related to obesity. And specifically, my task is related to the endocrine modulation in obesity. And this is obviously a difficult task. All were a very difficult task. I will try to focus on a few issues. This is the potential conflict of interest related to the topics I'm going to discuss with you today. And the first message I would like to remind, you all know that very well, but obesity is the consequence of a positive energy balance. And in our society, the large amount of the high prevalence of overweight and obesity that we've been seeing in the previous presentation is related to an increase of energy uptake. This is the driving force leading to obesity. So the outline of my presentation is going to be focused on three major issues: a metabolic issue related to the mechanism, the adaptive mechanism related to weight gain, and this will give me the possibility to revise in a consistent manner the previous presentation with just few difference in terms of interpretation of the data. Some issue related to the endocrine adaptation, and finally, just a quick touch related to the increasing importance that we all know that it's obviously extremely important, but we realize that we need to know more, not only related to all these crosstalks in between organ and tissues with the central nervous systems, and in particular of the adipose tissue, but also the gastrointestinal tract is extremely important in regulating our behavior, as we have listened in the previous presentation. So this is exactly the same message you got in the previous presentation. These are two individuals with exactly the same body mass index, but as you can see from the profile of these individuals, body fat distribution is different. This individual has the typical gynoid distribution. This is an android distribution. This is the visceral accumulation, thin legs, thin arms, in contrast with this individual in which body fat is distributed in a more uniform manner. And the message here, as previously discussed, is related to the fact that there are different metabolic profiles in terms of substrate availability in the bloodstream related to glucose, related to lipids. And in general, we learn to call this profile as the metabolic syndrome and this profile as the healthy metabolic profile, which we believe is strongly related to the risk to develop cardiovascular complication, micro and macrovascular complication, especially in people with type 2 diabetes. And this individual seems to be rather, at least a little bit more protected than this other in terms of the development of these vascular complications. So this is exactly the same message you have learned a couple of presentations ago. Not all the obese individuals are the same, and this is a way we try to give this message. This is an epidemiological retrospective observation. It's in the general population. They are not diabetic, they are not obese. These are individuals, almost slightly more than 2,000 individuals. In Lombardy, in Italy, 3 municipalities were involved. The major one was Cremona. And we measure in this study many, many years ago the anthropometric features in this population, some biochemical data related to this middle-aged Caucasian individuals, and then 15 years later, we went back and measured what happened to these individuals in terms of cardiovascular mortality, cancer mortality, but most importantly in terms of survival. And this is a very important art point, since there is no possibility to make a mistake in adjudicating the end point. So we segregated the population in 4 subgroups, depending on obesity, using the classical BMI as surrogate marker of obesity, and we split the population in non-obese, less than 30 kilogram per meter square, or obese, higher than 30, and in terms of insulin resistance, using the classical surrogate marker of insulin resistance, the homeostatic model assessment insulin resistance, the HOMA-IR, which is basically the product of fasting plasma glucose and insulin in the morning. And the higher is the value, the higher is the level of insulin resistance, the lower is the value, the lower the degree of insulin resistance. So the population was split in those with the HOMA-IR less than 2.5 or higher than 2.5, as insulin sensitive with those with the lower HOMA-IR index and insulin resistant with the other. This is an arbitrary choice because this was performed exactly in the same way, using exactly the same cutoff points in an American population in the NANES study just a couple of years before. So we had 4 categories: the non-obese insulin sensitive, the obese insulin sensitive, the so-called metabolically healthy obese individuals. And then we had the obese insulin resistant and the non-obese insulin resistant. And we went back for 15 years looking at the survival of these individuals, no matter whether the cause of death was cardiovascular, was cancer, was a car accident, or whatever. But this is the survival curves during the 15 years, and you can clearly see that indeed the insulin resistance is going to make the difference and not the BMI, since the trajectories of the obese insulin resistant and the non-obese insulin resistant were characterized by the worst profile in comparison to the non-obese insulin sensitive and the obese insulin sensitive. As I said before, the classical metabolically healthy obese individual. So the main message here is that it's not obesity per se which is making the difference, but is the insulin resistant condition as defined using the HOMA insulin resistant homeostatic model assessment. As was mentioned before, we have to take into consideration that there are different ways to give this definition of metabolically healthy obesity. Using HOMA insulin resistance as a surrogate marker for the definition of the metabolically healthy obese, you can clearly see here that indeed the prevalence of metabolically healthy obesity within the population is extremely low. In the population of 2,000 individuals, just 43 met the criteria. And this is approximately 11% of the obese population. We have learned from the previous presentation that there are potential metabolic mechanisms explaining why these individuals may be protected from a poorer prognosis in comparison to the insulin-resistant individuals. And I'm going to show you some sort of different potential mechanism. Generally speaking, these obese individuals have been always studied, interventionally speaking, using experimental approaches aimed at reducing body weight to see what's going to happen in terms of adaptation, using a diet, using the exercise, using bariatric surgery to these metabolically healthy obese individuals. This is a very smart study performed a few years ago using a totally different approach. They are obese, but still they need or they have to undergo a program in which they are supposed to gain additional weight to see how they behave in comparison to the so-called metabolically altered individuals. And again, the adipose tissue was taken into consideration specifically in these individuals. These are the metabolically healthy individuals, metabolically normal obese individuals, metabolically abnormal obese individuals. And this is before and after the classical 10% weight gain. And you can clearly see that at the baseline level, lipolysis was running faster in the metabolically altered individual in comparison to the metabolically healthy individuals, and no change was observed following the weight gain. In contrast, in the metabolically altered individual, this difference showed a no significant but still a small increase. Interestingly, the response to insulin during the clamp performance was strikingly different. No matter whether they gain weight, the metabolically normal obese individuals maintain exactly the same control on lipolysis during insulin infusion, in contrast to the metabolically altered obese individuals in which insulin resistance with respect to lipolysis was present at baseline and got worse after weight gain. It's not just a matter of release of fatty acids from the adipose tissue, it's something also having and taking place at the level of the liver. This is the rate of secretion of VLDL using tracer techniques and looking at ApoB100 secretion rate taking place specifically at the level of the liver. And we can clearly see that the metabolically healthy obese produce less or secrete less VLDL, less triglyceride in the bloodstream in comparison to the metabolically abnormal obese individuals. And following the weight gain intervention, there is no change, in contrast with the metabolically altered individuals in which this was getting worse. And finally, going back to the adipose tissue, the other typical response of these metabolically healthy individuals was that the expression, as I said, at the level of the subcutaneous adipose tissue, the expression of genes involved with lipidogenesis was significantly increased in comparison with the metabolically abnormal obese individuals in which this adaptive mechanism was not detectable at all. So, in other words, excuse me, the paper shows clearly that these metabolically healthy obese individuals behave adjusting metabolism of free fatty acids and triglycerides, free fatty acids at the level of the adipose tissue and triglycerides at the level of the liver, stimulating lipidogenesis and increasing, expanding the capability to store the excess of energy within the adipose tissue. And we had produced very similar data, again using the same traditional way to segregate the metabolically healthy obese individuals in comparison to the metabolically unhealthy obese individuals, performing very classical whole body energy metabolism study using indirect calorimetry techniques. And we noticed something similar, resembling the previous publication, showing that this group of metabolically healthy individuals perfectly match in a cross-sectional fashion in comparison to the metabolically unhealthy, showed no matter whether the turnover rate of energy was the absolute value corrected for the free fat mass or corrected in another way using the percent of the predicted resting energy expenditure using a prediction equation, was consistently lower in comparison to the metabolically unhealthy obese individuals. And this makes perfectly sense, and it perfectly correlates with the availability of substrates in the bloodstream. These individuals have higher fasting plasma glucose, have higher fasting serum FFA concentration, and their metabolic turnover is higher, probably due to the higher availability of the substrate. A small difference is something that we had the possibility to meet many years ago in individuals with a BMI less than 27 kilogram per meter square, and individuals not truly overweight or obese, or not necessarily overweight or obese, but segregated based on the level of insulin resistance at that time using the clamp techniques, were characterized by a fasting disposal of energy focused on the use of FFA rather than glucose. This is the respiratory quotient significantly lower in the metabolically healthy obese in comparison to the metabolically unhealthy. That means a relative preference with respect to fatty acid disposal in terms of oxidative pattern of the disposal rather than the metabolically unhealthy. Very similar to the data produced many, many years ago. This metabolic adaptation, it's not something taking place of detectable simply in obese individual. This is another very old paper we produced back in 2006 in obese adolescents. And in this case, the discrimination, let's call it this way, in between healthy obesity and unhealthy obesity was different, because the unhealthy obese adolescent was the individual with an excessive amount of fat within the liver, with a fatty liver. The healthy was the individual, the obese adolescent that despite obesity had exactly a normal amount of triglyceride within the liver measured using proton NMR spectroscopy. And you can clearly see exactly the same trend once more. The individuals, let's say metabolically obese, the adolescents without fatty liver, consistently lower respiratory quotient with the classical flexible response during the oral glucose tolerance test, giving orally glucose, the respiratory quotient increased significantly, showing the flexible switch from FFA to glucose, in contrast with the insulin resistant with fatty liver obese adolescents, in which the respiratory quotient was higher and almost no change during the oral glucose challenge. So this is just to remind you that even if the interpretation of the data may be slightly different in comparison to the previous presentation, the message is exactly the same. In the condition of overfeeding, we may have individuals able to perfectly and promptly store the excess of energy introduced with the diet within the adipose tissue without any spillover, as we learned a few minutes ago, in the bloodstream, without the need that this other, let's say, more nobile tissue, we need to buffer the excess of substrate at the level of the bloodstream. In contrast, we may have metabolically unhealthy obese individuals in which the adipose tissue shows some sort of failure. This means increased availability in the bloodstream and increased accumulation in the ectopic sites, and particularly the liver seems to be, also clinically speaking, the typical manifestation of this failure of the adipose tissue in storing the excess of energy. The situation is obviously complex, and my effort in the presentation, especially for the next few slides, is trying to give you an insight in summarizing what are the secondary, most likely secondary adaptation of the endocrine system in people with obesity, and whether we might have a small chance in correcting this maladaptation in terms of getting some sort of good endpoint, body weight, cardiovascular risk, lipids, plasma glucose in people with obesity. Hypogonadism is detectable in obese individuals. We do know that obese individuals have lower testosterone levels, but also lower sex hormone binding globulin levels, but at the end, totally speaking, the free testosterone, even if there is discussion whether it's important to measure the total testosterone or the free testosterone, is lower in obese individual. And these abnormalities may be reverted thanks to the body weight reduction. And there is always a lot of discussion related to the possibility to get some sort of beneficial effects in terms of replacing this testosterone in obese individuals in order to get at least, most likely, a better body fat distribution. The other condition of, in this case, this is obviously low testosterone, this is high testosterone, the polycystic ovary syndrome, very frequent and common within the population, and most of the time associated with overweight and obesity. The interesting issue here is that even if it's always the very well-known chicken egg story related to its first insulin resistant and then ovarian abnormalities, or the ovarian abnormalities is primary to the development of insulin resistance, I have to be honest, I still don't know, but I have the feeling that based on the data related to metformin, which is not strictly speaking an insulin sensitizer, but is similar to an insulin sensitizer, but most importantly, thiazolinoliones, which are typically insulin sensitizer, these are extremely useful, at least in one endpoint, in obese women with the polycystic ovary syndrome, which is fertility. Maybe they are not useful in terms of reduction of body weight, but they may determine an improvement of fertility. Growth hormone, very similar story with respect to hypogonadism. It is described low growth hormone levels with increased circulating binding protein from growth hormone, but problematic is the fact that insulin-like growth factor 1 is normal. And since the metabolic effect of growth hormone is mediated largely by insulin growth factor 1, which is produced not exclusively but largely by the liver, it is possible that there is very little beneficial effect in terms of hormone replacement therapy, giving growth hormone to obese individuals. It's a controversial matter, especially for the undesirable side effects. This defect is reversible with weight loss. Cortisol, obviously, it's a very important chapter with respect to this issue. There are a lot of data in the literature showing that in obesity, the response to many different sorts of stimuli of the pituitary cortisol, cortisol, it's deranged, and no matter what is the text. And most importantly, we all know that cortisol is produced by cortisone, by this enzyme, 11-beta hydroxysterol dehydrogenase 1, which is largely expressed in the adipose tissue and somehow may favor the conversion of cortisone to cortisol at the level of the peripheral tissue and somehow determining some sort of increased activity of these hormones. Most importantly, there is also the fact that overweight, obese individuals are most likely characterized by an increased activation of the sympathetic nervous system, and you can detect it very easily during your visit in clinic based on the heart rate, which in these individuals is most of the time higher than in normal weight individuals. The point here is, again, whether this is an adaptation, a normal adaptation to the obese condition, or a maladaptation which may eventually deserve to be treated in order to get some sort of advantage. For the adipose tissue, I'm not going into details related to the fact that the adipose tissue is an endocrine organ producing many, many hormones. Leptin was the first one, as you all know. Adiponectin, cytokines, chemokines, mediating also inflammatory mechanism related to the cardiovascular risk in association to obesity. The point is, my feeling is that at this stage, most of these endocrinological abnormalities are reversible with weight loss, and to me, it is apparent that these are secondary to the development of obesity. With respect to the crosstalk in between tissue, obviously this is a relatively old study, very much discussed, very difficult to understand whether this is a reliable message, reliable conclusion related to the possibility that the adipose tissue and eventually the liver may be able to produce some sort of key endocrinological messages for the beta cell in order to expand and to be, let's say, ready to the increased presence of insulin resistance in the natural history of type 2 diabetes. In the previous presentation, you all saw that with time, insulin resistance in normal healthy individuals may increase due to our lifestyle, but there is certainly adaptation of the beta cell, increasing the secretory performance in order to maintain normal plasma glucose, and indeed the adipose tissue, but potentially also the liver, may be responsible of this adaptive mechanism by means of the production of some sort of circulating key messages. Also, thyroid is extremely important. We all know that there are, and there is the description of many abnormalities associated with obesity in terms of thyroid function, even if within the normal, classical, typical function of the thyroid. And to be honest, we all know that the thyroid hormone works through two potential receptors. The B receptor is involved in energy, regulation of energy metabolism at the level of the adipose tissue and also at the level of the liver, and may be promising in treating at least these endpoints, if not obesity itself. Indeed, we also notice that in morbidly obese hypothyroid women, if you replace appropriately TSH level using levothyroxine, indeed you might get a metabolic profile which is even better than the non-hypothyroid women with the same anthropometric features. And the last slide is only just to give a touch related to the importance of the regulation of appetite, as we learned just in the previous presentation. We are used to listen to the role, the crucial role of the hypothalamus in regulating satiety, but we all know that it's not just a matter of the hypothalamus. We do know that two major peripheral organs, the adipose tissue and the gastrointestinal tract, may produce key messages for the hypothalamus, but also for other areas of the central nervous system, in particular the brainstem, which are involved not only in terms of satiety and sense of fullness, but also in the so-called hedonic feelings related to the food consumption, the pleasure in consuming specific foods, which are obviously not simply determined by a condition of energy status, but also of social feeling and pleasure in consuming food. And this is very well known because you all know that in the diabetes field we have a new class, relatively new class of drugs, incretin, which are able to increase the circulating levels of GLP-1, and GLP-1, especially when injected subcutaneously as a receptor agonist of GLP-1, is most probably able to determine, at least in certain individuals, modulation of these centers at the level of the brainstem, reducing the pleasure in consuming food. So the conclusion I want to give you: positive energy balance due to overfeeding triggers many adaptive and or maladaptive mechanisms. It's very difficult to understand which is a good one, which is the bad one. This complex setting of adaptation offers obviously many potential therapeutic options to be explored, even if, as a matter of fact, manipulation of this adaptive mechanism may result only in partial beneficial effects, which may be valuable, but also in unexpected outcomes, and sometimes also undesired unexpected outcomes. Apparently, bariatric surgery, and I believe there is a provocative presentation for you tomorrow, bariatric surgery seems to be the more successful therapeutic approach, and probably my feeling is simply because, going back to the very first slide, it goes deep in the heart of the matter. Bariatric surgery induces a negative energy balance, no matter whether it's restrictive or malabsorptive. Thank you very much for your attention.
So, Gianluca, I'm a little bit puzzled by your interpretation of the substrate oxidation data. So, basically, you actually said that the metabolically healthy obese have a lower resting energy expenditure, whereas in those subjects, actually the lipid supply to the tissues, including muscle, is actually also lower. So do you really think that it's indeed substrate availability that mainly determines substrate utilization, because those metabolically healthy obese had a higher fat oxidation, right? A lower RQ? Or is it more autocrine and paracrine mechanisms? Because well, I think it's the latter, but...
As a matter of fact, this is a consistent finding in our hands, even if in contrast with your data specifically related to what's going on within the adipocytes, because it's a measure, your assessment of oxygen consumption or hypoxia or increased availability, you have a specific measure within the single tissue. When we run indirect calorimetry techniques, this is in a whole body system. So it's very difficult to dissect out the role of the liver, the role of the skeletal muscle, the role of the adipose tissue, the role of the brown adipose tissue. It's very complex, obviously, and it's difficult to give you a definitive response in this direction. Nevertheless, we always see that when we try to find a correlation in between the oxidative disposal and the metabolic profile of our, let's say, in humans model, I'm not used to work with the animal models, but simply with humans, we always find this specific finding, which is those with the better metabolic profile are characterized, sometimes surprisingly, by a lower energy expenditure rate and preferentially related to the disposal of lipids. In this condition, we might think about the prevalence, since they are at resting energy expenditure, of the liver due to the utilization of FFA related to the prolonged fasting, and in part of the skeletal muscle. But these individuals were morbidly obese, so to be honest, I have no idea about what might be the contribution also of the adipose tissue, because relatively speaking might be small, but totally speaking it was large, because the BMI was higher than 40, so that might be an important contribution.